Hi, I'm Susheel Kodali. I'm Director of the Structural Heart and Valve Center at NewYork-Presbyterian Hospital, Columbia University Medical Center. One of the most important advances that's happened as a result of our collaboration through NewYork-Presbyterian is the development of TAVR as a field. We were involved with the early stage feasibility trials, and the pivotal trials were led by Marty Leon and Craig Smith here. And this really was the start of sort of the transcatheter revolution. These trials helped define which patients benefit, that this technology was feasible, effective, and it was a great treatment option for many patients who otherwise wouldn't have had lower risk treatment options. One of the strengths of NewYork-Presbyterian is our collaborative nature and how we work closely with our surgeons. They're involved intimately with the procedure, all aspects of the procedure. And this sort of combined learning that comes from a surgeon's perspective and an interventional cardiologist's perspective really help provide patient with the best care options. In some cases, patients are referred for a transcatheter option, and going through the evaluation, we realized that's not the best option for them and surgery is. In other occasions, patients are referred to surgeons, and we find out that surgery is probably higher risk and they're better served by sort of a collaborative approach. And it's that willingness to sort of think outside the box, to work closely together to provide the best treatment option that really provides best outcomes for patients. And also by the fact that we see so many patients, treat so many patients, we've seen everything and really understand the limitations of the technology as well as the strengths of the technology. One of the real strengths of NewYork-Presbyterian is all of the resources that are available, not only in cardiology or cardiac surgery, but across the disciplines and fields. We often see patients that are referred from oncologists or pulmonologists that have some unusual anatomies, unusual complications that complicate their overall picture. And working with sort of across these disciplines and across these fields and having these resources available is really what helps us give patients the best care possible. I think the access to clinical trials really opens up treatment avenues for many patients. Whether it's a trial to sort of help refine the treatment options for patients and better understand how different patients react to these treatments and help define what's best for patients, I think that's a great option. But for many patients who don't have options via the traditional route of surgery, the access to these clinical trials really provides treatment options where none existed before. Over the last decade, transcatheter aortic valve replacement has really evolved into a field and is much more defined. However, in terms of treatment, transcatheter treatments for both mitral and tricuspid disease, we're still in its infancy. We don't know what devices work. Are there devices that work? We don't know which patients should be treated, whether they should be treated medically, surgically, or with transcatheter options. We're involved in at least 3 trials for tricuspid valve therapy, 3 trials for mitral valve therapy that are going to help define which patients will benefit from transcatheter options and also whether these devices actually are effective for these patients. And I think over the next decade, I'm hoping that we'll have better options to treat mitral and tricuspid disease via transcatheter approaches. And I think NewYork-Presbyterian will be at the forefront of helping to understand who will benefit and with which therapies. So over the last decade, TAVR has evolved from a therapy that's really a niche therapy for patients that don't have options to really the preferred therapy for many patients. Now, we've also using that data, have moved down to study it in lower risk patients. You know, we need to see if it's just as effective in that population. And as we move to lower risk patients, we got to really understand the durability of these devices. I think it's a great option for many patients, but we have to make sure it's the right option for an individual patient. If a 60-year-old is getting TAVR, is it providing what they need compared to an 80-year-old getting it? And I think these lower risk trials are going to show the acute short-term risk, but more importantly, they're going to show the long-term benefits of this therapy and which patient population it's appropriate to utilize it in. I think one of the advantages is as TAVR has become more defined, it's also allowed us to think outside the box. And I think working with our surgeons, working with our imagers and cardiologists, TAVR isn't just limited to using it for aortic valve disease. We've used it in mitral valve disease, in patients with a prior mitral valve that's failing, in tricuspid valves, in pulmonics. We've used it in scenarios where we've implanted it in the inferior vena cava in patients that have severe tricuspid regurgitation.